Afternoon, everyone, and welcome to the first in a series of webcasts that we're doing from Compass Healthcare to explore the really important links between key healthcare support services and our clinical partners, be they the NHS, private healthcare, or in some cases, care settings. And we are going to be kicking off very topically this first one with a focus on the lessons that we've learned first time around from the initial phase of COVID and how we might incorporate some of those lessons with our partners going forward for the possibility of a second wave. It's obviously quite topical at the moment. There's quite a lot of talk about a potential second wave and a spike in infections. As I'm sure if you're following the news, you'll know that in parts of mainland Europe, similar countries are experiencing some form of a second wave, not quite to the same extent. So we've got to be on our guard and ready to learn the lessons we've learned and step forward if that's the case. I'm joined by a great panel today, a real good mix of individuals who are going to make this an exciting webinar. We have Ian Murphy, our Managing Director of Foodbuy. Despite the name, Foodbuy doesn't just buy food, it buys lots of non-food items as well. It serves both internal and external customers for Compass. We've got Anna Hallis, who's our Control of Infection Lead for Medirest and Healthcare, and Anna's been very instrumental in helping to develop some policies actually in association with NHS&I. So she's a very valued member of our team, and as you can imagine, been quite busy during COVID. We're privileged to have Peter Wilson, Professor Peter Wilson from UCLH, our clinician with a specialism for antibiotic advice and obviously infection in critical care settings. So that will be extremely relevant. Peter, thank you for joining. Catherine Pegner, who's MD of GV Health and one of our key partners for consumables, waste management, all kinds of other things, PPE in particular. I'm sure that's kept you awake recently, Catherine. So again, thank you for joining. And you know, very, very delighted to have Gareth Donaldson on the call. Gareth is one of our contract directors, so he is responsible for the Royal Surrey contract, which delivers a multitude of support services via the Compass team. And I'm particularly keen that he joined this morning, so he could give us a view from the front, as it were. So that's our team. I think it's fair to say, so I'm going to speak a little bit more at the beginning now than I will during the webinar, so don't panic. I'm going to involve everyone shortly. But I think the term once in a lifetime event has been used quite a lot. And I think for the first time, it's probably that isn't hype. It's true. We were all learning on the fly, both clinically and politically, and you can see all the ebb and flow of those decisions coming through now. So it is good. It is timely to look back and see what we did and see what we could have done better or did right. And I'm sure these decisions, as Professor Wilson will confirm, are happening clinically, but equally they apply to us and how we can, the things that we do, the actions that we take can support our clinical partners. So very timely. It isn't going to be about other support services. So whilst I acknowledge the importance of hard FM, so the sort of M&E type of services that are delivered into healthcare, of course they are vital too. We're going to be focusing primarily on those services that are principally people related. So for those of you who are in the industry, you'll know the core four is principally cleaning, portering, staff and visitor feeding, and patient dining. Of course, there are other services such as security, which we deliver, but those generally are the core four. You might be surprised to know, and Professor Wilson, I'm sure will confirm this, that after the first 2 or 3 weeks of intense activity where things really were a form of controlled chaos, acute hospitals have been relatively quiet. The number of COVID wards have been reducing, and I've heard probably for the last 12 weeks from most of my team out there that the hospitals are still relatively quiet, and that's because they were effectively emptied out to treat a single disease, and as that disease has receded, the hospitals have not yet filled back up or back up to normal capacity. So we are in this kind of strange position where there's a bit of calm at the moment, and again, that might be good planning to anticipate a second wave. The other end of that argument is that, you know, are we switching on more elective surgery or more routine and ritual? Should that be accelerating? And that's something we hope to explore during this webinar too. So I hope all of that sets the scene. It is a bit long, apologies for that, but I'm not going to jump straight in, and I'm going to make no apologies for starting with Gareth, actually. Gareth, I'm going to put you on the spot, and I just want you to cast your mind back to that time I was describing, where we went from kind of we're ready to almost a form of controlled chaos for 2 to 3 weeks. You deliver all the services down in Royal Surrey. Just tell me in your own words what that period was like, and what the key kind of features of that period were.
Afternoon, Steve. Afternoon, everyone. Yeah, I guess to roll my mind back to those kind of 2-3 weeks of chaos, as you mentioned, is quite reflective. Thank you for allowing me to come on the call today on the webinar. It's a good opportunity to actually speak from the cold face and kind of give a bit more of a truer outlook of what we were facing into during that period. I guess I'm lucky in the sense that at the Royal Surrey, where I operate from, I operate a vast array of FM services, like Steve mentioned, as well as the retail services. So I got a bit of everything in terms of that impact piece. I think from a day-to-day running perspective, the way that the information flow was moving so regularly, that created quite a lot of uncertainty on the ground, especially for a business that is driven mainly on compliance and KPI performance. I guess also the realization for my team and myself that it wasn't just a KPI score that we were looking into, but actually there was a human impact potentially at the back end of we weren't doing what we were meant to be doing properly. So it added a lot of extra kind of complexity and pressure, if you want to call it that. I guess from a delivery method point of view, as the hospitals were kind of expanding during that 2 to 3 weeks, there was a lot of other questions being asked of us as well as a team, not just around cleaning and catering, but how we could support the wider hospital kind of community in terms of how they were dealing with the issues that they were facing. Because strangely enough, I think everyone now knows that a lot of this stuff is you only know what you know, and you have to kind of pick up the pieces as you're walking through the process. I think in terms of a team perspective and keeping the motivation, and that's not just the Medirest team, I think that's the wider community within any NHS trust, not just the Royal Surrey. I think that first 2 to 3 weeks was challenging and tricky, to be honest. And just to keep everybody kind of moving in unison and making sure that information flow, even how checkered or staggered it was coming through to ourselves, was being given to them concisely and in a timely fashion to ensure that their kind of fear and kind of anxiety was measured as well. And I think that for me was one of the most kind of biggest learnings that I took from the process, is that communication flow and how we actually deliver that to our teams. I guess one other point just on that first 2 to 3 weeks, as the rules were changing, or how social distancing was evolving and how lockdown was obviously getting kind of staged, we came to different barriers in terms of how that communication flow could actually be delivered. Like all businesses, you will have a set framework in terms of how you want to push that information out to your frontline team. To put it in perspective, I guess I've got one of the medium-sized teams within Medirest, so about 450 colleagues also at Royal Surrey. To touch them with all the different changes from a PPE perspective, from a virus perspective, from a trust perspective, was challenging, especially because you couldn't meet in large groups. So we had to think a little bit outside the box, and I think some of those learnings will actually end up following us into post-COVID, if that makes sense, because they're more valuable and more impactful. And in some cases, we actually managed to drive a lot more change quicker through those different formats. So it's just something that made us think differently. So I guess there's a positive that came out the chaos, really, Steve.
Okay, and I guess like all of us, there was somewhat there was a fearful element to trying to understand this terrible new disease, and that affects everyone, including our own teams. So absence was quite a key measure in the early days, wasn't it? Where we had a spike in absence, as you can imagine, some genuine, some fearful, some related to self-isolation, some shielding. It was quite a pressure for you, wasn't it? Delivering, suddenly you had absence rates that were 3 or 4 times your normal run rate. So how did you cope with that? How did the company help you to cope with that?
I guess we're lucky in the sense because Compass is obviously a large family, so we can lean on other support partners to assist us through times. I mean, one of the key helping hands that we got was from our Levy colleagues. Obviously, their businesses was going through elements of change, and we had a surplus of staffing within those areas that we could pull on. That mobilisation happened very quickly and very swiftly. And to the credit of Compass and Levy as a whole, I think it was delivered really well, and well received by my clients in particular, as well as I believe all the other NHS trusts who managed to benefit from that service. Yeah. I guess the other mind shift that we had, obviously I mentioned in the beginning, was that we look after retail services at the Royal Surrey. Mm-hmm. So in a lot of cases, those businesses were going through obviously a mass sales decline. Mm-hmm. And within all retail business, all based on kind of sales volume, which gave me the ability to think differently and try and redeploy my own internal team into a more pivotal role within the FM services. Yeah. And again, that was helped and assisted by our kind of internal Compass processes, yeah. And I'm sure Anna will go into it at some degree when she talks later. But getting the right training and the right kind of support for those colleagues so that they were facing into the storm, if you would like, with all the tools and kind of guidance that they required.
So I guess what you're saying is that in some ways the sort of challenges, the intense challenges you had, created a need for more flexibility that you got to more quickly than you would may ordinarily have done during a normal period. So in some ways that enabled you to make those changes quickly, and having that additional labour facilitated that. So just hold that thought for the time being. I'd like to come to Anna Hallis, if I may. Hi, Anna. Look, we know that, and I'm sure Professor Wilson will concur, that infection of all kinds is part of our world. It has been for many years. I can cast my mind back 10 or 15 years when MRSA first hit the public headlines, and then C. difficile and issues like norovirus and many others since. So dealing with infection and the control of infection in hospitals has always been part of our world, hasn't it? Whether it be barrier cleans or isolation cleans that our cleaning teams do. Obviously, COVID, and Professor Wilson will have to educate me here, its level of infectiousness probably compares to many of those, but its effects are potentially in the wrong, if it affects the wrong people, more deadly. So how did you kind of adjust your thinking from the sorts of infections that we routinely have to deal with and help our clinical colleagues in hospitals to manage, and the new COVID one? Where did you see that in the hierarchy, and how did you go about reassuring people or alerting them, or whatever it was that you decided to do?
I think it's fair to say that we didn't actually understand it at all when it first came over. It was considered to be a high consequence disease, and what we've done is we've learned on the job very much through this pandemic in terms of what we need to do from an FM support services perspective in supporting our clinical colleagues to deal with COVID-19. So we learned as much as we could. And actually, there's been a collaboration between all the FM suppliers, which has been really good, where we've developed procedures and we've dovetailed those to the Public Health England guidance. So everything that we've done, as soon as new guidance comes out, we've provided new processes and procedures to make sure that our teams at the front end benefit from the latest advice and guidance. Mm-hmm. And it has changed through time. So it has changed from where we first started and what we first knew about the disease and how we needed to manage our services to actually what we're doing now. As you said at the beginning, everybody's learned on the job, and actually we learned very much on the job with this particular disease. And it hit the sites very quickly, and so we needed to be very agile about what we did and how we operated. So our normal procedures for cleaning were still in place, so we still clean the way we always clean, but we protected people differently. So we had procedures for within 2 meters of a patient, outside of 2 meters of a patient, and where people were being treated for high risk areas. And then we also looked at all the different areas of a hospital that were being used. So as you said earlier, hospitals became very quiet, so lots of outpatients closed. and lots of areas increase their capacity for intensive care. So it's about being agile and understanding how each trust was working and how each hospital was working, and making sure that we've got all the relevant guidance in place. Our teams understood the PPE they needed to wear, they understood the procedures that they needed to follow, and that we provided training and support for colleagues based on that changing world, really, as and when it changed.
That's an interesting point, Anna, because I certainly recall many discussions we had about trusts, interface with certain trusts. We have about 20 clients up and down the UK, and each of them had a slightly different variation on the theme. Now, I'd like to come to Professor Wilson on that particular point and ask you, Peter, how do you balance the needs of an individual trust versus what might be coming out of Public Health England, what might be being advised by NHSI? It's a difficult balancing act, isn't it? Because there has to be a tailored approach by hospital and trust, but equally trying to make sure that we key into central government instructions. And I think Maskgate is a good example of how things have ebbed and flowed. How do you balance that, Professor? You're just on mute at the moment.
It's been a learning experience, definitely. And I mean, the chief medical officer is actually one of our consultants. So we sort of sympathized with him as to the situation and predicament he was in and is still in. It's almost a no-win situation because you can produce advice based on the circumstances at the time, but because this is a new disease, next week those circumstances have changed. The mask issue was a case in point. Initially, the government was treating this as like another influenza outbreak, where the thing to do is let a certain number of people get the infection, raise the immunity of the population, because and vaccinate as soon as you can. And of course, what they hadn't worked out was that the level of mortality and more particularly morbidity, the chronic illnesses that were associated with this, and nobody had actually really come to grips with. And maybe we should have, maybe if there'd been better information coming out of China, we would have perhaps got wise to that earlier than we did. So you've seen that masks were not initially used very much, and we were said actually they don't make much difference. And now you've got masks that are mandatory, so it's a complete turnaround. There were enormous numbers of publications and guidance that came out of various bodies, and there have been one or two which have been completely at odds with everything else. So, for example, we had the Royal College of Surgeons saying you should turn the ventilation of the theatres off. And that's completely the wrong thing to do, because you need the ventilation to dilute the virus. So that had to be removed. We've had enormous problems with distancing and transmission of infection between staff. And it's not in the ward that the staff are catching the infection. It's not near the patients. It's in the tea room.
Interesting.
It's in the socializing afterwards. And sometimes it's in the travel into work, but it's not in the hospital. And there's been a lot of outbreaks associated with social events that the staff have gone to. So that too was a real learning. As far as cleaning goes, it's been not so difficult. The virus is very easy to get rid of from the environment. It's easy to kill. And we have tested the environment quite extensively, and we only find the virus in the near patient area in the first week to 10 days of the admission. After that, it seems to disappear.
So it has a sort of a shelf life.
It has a shelf life, yeah.
Yeah. That's really good advice and good reflection. Certainly, a lot of what you said, I'm sure, will be clinically adopted going forward. And similarly, on our side, the mistakes that perhaps we made in learning will also be incorporated. And of course, that's the point of the webinar today. So I'll come back to you in a moment, if I may, Professor. But for the time being, given what you've heard, I guess it'll be Ian and then Catherine in that order. The pressures, the sort of ebb and flow of demand, masks, no masks. I think we had Soapgate at one point where there was a chronic shortage of liquid soap, all kinds of things going on. What are your reflections, Ian, on that? And then perhaps you can hand over to Catherine, because she's on the supply side trying to keep to grips with all these this moving feast that we're demanding. So what are your immediate reflections, Ian?
Yeah, sure. Thanks, Stephen. Thanks for inviting me on the webcast. I guess the first and foremost thing was, as Gareth said, it was an ever-evolving situation, and for Foodbuy, we look after about £1 billion of spend across our clients. So quite quickly, my team needed to establish which parts of our clients were continuing to operate during this period and which clients weren't. And I think that was kind of the first priority, was to try and really understand where the demand was coming. So we saw quite a number of our clients close during this period of time, but actually we saw big peaks in demand across hospitals, defence sites, schools, and some of that key infrastructure that keeps the country running. So we had to help our suppliers really understand where the ebbs and flows in demands were coming, and help them understand, therefore, also what types of products we need. And I think my biggest reflection of this period of time was that while we bought PPE for healthcare for a long time, actually that became the kind of most in-demand supply chain I think I've ever experienced, ever witnessed. The demand for that supply chain versus the supply was just in levels that we've never seen before. So I think so we had to, I guess the key things we did in the first phases was make sure we understood where the priority clients were, and then try and use the great data and the great supply chain that we have in Foodbuy to figure out in the most robust, safe, transparent way how we could satisfy this crazy levels of demand that we're seeing, predominantly for PPE type items. And actually also what began to transpire is week by week the demand for product and the shortages on product seemed to change. In the early phases it was masks, then we moved into soap and hand sanitizer, then most recently into gloves. So I think it's been a constantly changing feast in terms of where those challenges have come from. And we were incredibly grateful through this period of time that we have such a robust and strong supply chain. And the fear for me that I saw in the market was that there was a lot of suppliers popping up overnight, and the integrity of those suppliers and the robustness of those were just not where we would ever consider purchasing products from. So we were really pleased that we had such strong partners that we could rely on, and they worked incredibly hard to help us through these difficult periods of time. But I was fearful for what the wider market was doing, and some of the challenges that faced. And then just before I hand to Catherine, I think what we also did during this period of time, and Gareth alluded to it when he talked before, is we also took advantage of the supply chain we have outside of non-food to help as well. So in the early phases, the supermarkets were getting hammered by people for product, and people were stocking up, and therefore we felt, especially in those early phases when people in hospitals were struggling to get out of the hospitals, and when they were getting out, their ability to get access to food and to key essentials was nearly impossible. And the food service supply chain has different pack formats and size of products to what the retail supply chain would have. So we quite quickly did two things. We took the catering pack formats and installed a process where our sites could repack those and therefore offer them to Medirest, but also to the trust staff, so that they could access those products that they would find it difficult to get hold of. But also I think what we did really well was actually recognise that just the hard work that everybody in this sector was putting into the ever-evolving situation. So we also arranged for some care boxes to go out to all Medirest employees.
Yeah. So I think you're being a bit modest there. I think it was 7,500 care boxes that went to individuals, and I can remember the smile on people's faces, particularly when some of those essentials were not readily available. So I think you may be hiding your light under a bushel there, Ian, but no, on the motivational front, it really did. It had a disproportionately positive effect. I was surprised at how much people valued that, but carry on.
Yeah, and I'm just going to hand over to Catherine now, but I think one final reflection from me was we also helped organisations outside of our own networks. So I think in this period of time, once we got through those first few weeks of uncertainty, what we could then do is help organisations, competitor organisations we never worked with before to get access to these products. So I think it was like a national emergency rather than a Compass issue, and I think the ability to help other organisations is something that I would definitely reflect on and cherish, and we helped some really vulnerable kind of charities as well during that period of time, and I think that will go, you know, that will last long in the memory for the future.
Yeah, there was a little bit of a national blitz spirit, wasn't there, at that time, and I think you know, we've always had a close working relationship with our clients, particularly the NHS, but I think it was really shoulder to shoulder at that point, and something to be cherished and celebrated. So over to Catherine then. Catherine, obviously you're on the supply side of this discussion, and you know, the first thing I would think of is all the various specifications of masks that were flying around. Suddenly we all became experts in FP3s, and you know, we had to have all this kind of specialist knowledge. How did you come up to speed quickly? Obviously, it's your day job, and that's what your company does. But I can imagine that the changing specifications must have been a bit of a challenge for you.
I mean, actually, interestingly, firstly, hello everybody. Interestingly, listening to everyone speak this just now and thinking back to March, which just I realised how long ago it seems, and also how much I've forgotten or maybe just cut out. I don't know, but. I think the key thing is that we found that literally overnight, for us, not so much on PPE, although I can come to that later, it was for things that Anna will be very familiar with, which is the key cleaning products within hospitals, so your chlorine products. You imagine that we suddenly saw overnight a demand from sort of 20 times more than we normally produce. What we had to do was we sort of, we not only invested in manufacturing, but we actually had to just make a conscious decision to actually just turn off all export so that we could prioritise the UK to be able to sort of cater for the demand. And I mean, in terms of, I mean, that's from the chlorine side. For things like the bags, again, overnight it changed from sort of 4 or 5 main waste streams over to NHS England sort of stating that you've got to assume 80% of all beds would be COVID. Therefore, you've got to move to alternative treatment, the orange waste bags, which so we, again, with UK manufacturing, we managed to be able to provide not only the huge increase in healthcare, but actually that was across the board. And Ian, you alluded to it as well. It's not just in the healthcare, it's the other stuff that goes on, you know, going out and finding food. The other sectors, we found that county councils, fire brigade, police, schools were all sort of really desperate to get hold of these products. And I think for me, I keep coming back to, and it's the thing I want us all to learn from, is the fact that we just did not have enough product in place, enough PPE in terms of, and Ian, you were saying about gloves, masks, and how it changes about what is available. But the other thing that really sort of came home to roost was the fact that with the pandemic, we're not the only country that need those products. So of course, the demand is just too huge, and you can't just turn it on. So for us, we've been sort of building as much stock as we possibly can and making sure that we continue to filter and cater for all the customers. And in terms of what we've managed to sort of increase our manufacturing capacity, we've done it 8 times more than we normally do. So I think that we have achieved quite a lot, but there's still lots to go. And again, my feeling is that going forward and potentially with a second wave, and as I said, March does seem a very long time ago, that we don't forget and think that actually now that we've had several months, that manufacturers or suppliers will just be sitting on vast quantities of products because that everyone's still catching up. We're still using vast amounts. We are providing something like over 10 40-foot containers of aprons just direct to the NHS central distribution point every week. And that's just to keep them going. That's not building any buffer. So it starts to give everyone an idea of the sort of quantities that we're talking about. But I think you know, Ian alluded to it. I think it's the sort of the blitz. Everyone has worked amazingly well together. We've liaised with Anna and made sure that we've got effective literature. Our websites have been updated where we feel that, say, care homes have been somewhat left out and neglected. We've put together marketing so that they have an idea about what's going on and how to effectively manage things. But yes, it's. I have to say, I think, Steve, you said it was a once in a lifetime. I don't really want to do this again.
No.
No,
I totally agree. And what about this vexed question of because as you say, we in this country we're tending to think that the pandemic is for the time being under control. I hate to say that because we are a nanosecond from losing control. But of course, in the rest of the globe, there are more infections and more deaths than ever before. So that international demand for PPE is still there. Maybe it's even a greater demand. So where do you stand on this vexed question of domestic manufacturing versus midnight planes from Turkey full of PPE that may or may not meet the specification? Where are we with that? Because surely that's one of the learnings, isn't it? That
absolutely. I think the fact is that, I mean, for us, our supply chain has had to be hugely robust, and we manufacture both in the UK, also in Europe and the Far East. And the great thing about that is you can then flex. You know, if when this whole pandemic really took hold, China ground to halt. So the whole problem was not only had they mopped up all the PPE, they then stopped manufacturing. So that was also, for a good month, nothing was being manufactured. And it is, as I said, it's not just the UK that requires it. We do have to learn from the fact that actually we need to be able to manufacture both in this country, I mean, all over. And as the pandemic is moving around, as you quite rightly said, there'll be times when actually certain areas of our supply chain are not operating. So we have to be able to have alternatives.
And have you had any luck in encouraging, perhaps assisting the establishment of national supplies, or is that some way down the track?
We have had very successful collaborations with UK manufacturer, both in terms of for Orange, we managed to basically we had one that was just making the orange bags 24/7, and also on things like face shields. A food packaging company we've joined forces with and have started to make face shields. And I think it is very important in terms of it's lovely to see manufacturing in this country. The problem we've got with the NHS is that actually it is so price sensitive. That's why so much manufacturing has been driven to the Far East, because their budgets are so tight. And when you work on the basis that something like an apron is 2 to 3 times more expensive if manufactured in this country, you can see the issue that they have. So I guess that's still the hurdle that we've got to get over. But I hope that actually what this has taught us is that, in fact, if we can invest in more UK manufacture and we can produce more, that actually in time that they will align a bit more anyway. So.
Thank you. I think that's kind of good to know that it's underway in any event. Now we will come off of control of infection in a moment, because obviously there is more to the services we deliver than that. But I do want to just ask Professor Wilson one more time, given what we know now, has the advice around the PPE that both our operatives wear and clinicians wear, is that moving significantly? I know we've talked about the mask thing already, but generally, is there a different specification for layering, for distancing, for double masking? How have things moved in your experience, if at all?
Well, I think at the beginning, the emphasis was on the FFP3s, and they were being worn in every area where we thought there may be COVID patients. It was only sort of after several months that things were relaxed, and as non-COVID patients started coming back into the hospital, then it became more acceptable just to use the ordinary masks. But what's accompanied that is more intrusive distancing. Mm-hmm. And that's been a big problem in the hospitals, as you can imagine. It's really difficult for staff to maintain a distance, even of 1 meter from a patient, let alone 2 meters. And indeed for patients themselves to be distanced from each other. So, I mean, our hospital, like many others, was faced with, well, either you lose 1 in 6 of all of your beds because of distancing in bays, or you put partitions in. Mm. We've seen in social arenas there are a lot of perspex screens. So in a lot of tea rooms now, there are perspex screens are starting to go up. So the screen is as good as maintaining the distance. Mm-hmm. And if you can't do either the distance or the screen, then you've got to rely on the mask. And the mask itself is an imperfect tool because you can breathe around it. You can put your fingers underneath it if you forget. Probably the most useful thing with a mask is to stop you touching your face all the time. Mm. But of course, if you touch the outside of the mask, you're going to contaminate your hands with whatever you've breathed in through the mask. Mm-hmm. So the PPE is very vexed, yes.
Very tough situation. And, having visited hospital recently, I can also vouch for the fact that they're extremely hot to wear. So when the directive came out about a month ago that everyone in a hospital needed to wear a mask all of the time, obviously it was welcome from a PPE sort of control of infection measure, but a lot of our individuals felt the individuals that we employ were just suffering somewhat with the heat. Particularly, and now with the summer that we're having makes it even more intense. So there's always a little bit of a unintended consequence, but I think the teams that are over time gotten used to the fact that they have to wear them all the time, and it's they have my utmost respect. So we could keep talking about obviously control of infection because it is the critical element of all this. Just turning to Gareth, we've heard how the pattern of work changed from pre-COVID. So we were busy ratcheting up, adding lots more people to our portering teams. But then we realized actually that portering profile and the jobs that they were normally doing changed. So give me just a quick overview as to how actually our expectations of who we needed changed over time as hospitals started to change how they operated, particularly in relation to portering. Tell me a little bit about that.
Hi everyone again. I guess if we're focusing on portering, our typical day, we would have kind of our elective moves that we're moving from A&E and across the hospital, general kind of periodic changes as well within the waste arena as well. We found that a lot of the bed moves that we would normally be seeing on a daily basis in terms of that demand was diminishing in line with the hospital kind of reducing their beds to kind of allow for the social distancing and so on to be created, as well as the hospital being in a full COVID state. To kind of counteract that, we looked at obviously our waste streams and how we could redeploy our porters and so on into other aspects within the trust to try and assist them differently. So there was a lot more kind of control of doors within our trust, so we were looking at how we could manage visitation through the hospital. So we implemented stewards. Again, we were looking at how we could kind of look at our disposal rooms and try and catch up with any sort of other periodic changes that were happening across the trust. Again, I guess within our housekeeping, I know that the housekeeping division, the cleanings remained pretty much the same. I guess the volume of cleaning, however, did accelerate considerably. I can speak from experience. Within that first 2 to 4 weeks, we saw almost 400% additional terminal cleans being requested. So I quickly cottoned on that I needed to redeploy my portering team within that housekeeping team relatively quickly to try and assess with that kind of added demand. Again, it was received well from the team. I must admit, I didn't have a huge amount of challenge in terms of motivation, in terms of changing those job roles and getting them more involved. I guess I don't know if I'm lucky in that sense, or if I stand outside the norm. I don't think so. I think it's just the healthcare way. But yeah, I think just that ability to be agile on your feet and trying to think how you can reutilize your workforce is definitely something that we have to take notice of, and be a little bit more adaptable and honest with our colleagues moving forward, that with the world changing the way it is, if we stand still, we'll diminish, and we have to be kind of able to assist our trust better. And they're on board with that, Steve, if I'm honest.
Yeah, and I can remember you saying, and many of your colleagues saying, that we'd gone from broadly a Monday to Friday business of intensity to a 24/7 business. So, we were all concerned that our managers, such as yourself, were intensely working for 60 hours in some cases, but the client expected 168 hours. So we needed 3 of you, and we had to work very hard to support the businesses. So, pandemics do create different patterns of design, and as you rightly said, they intensify in some places where you need more frequent, but in others they diminish. And that flexibility is something that I'm really pleased you were able to deploy to the trust's advantage. Now, if I could stay with you, if I may, Donald, Gareth rather, and then come to Anna as well. Patient dining generally diminished, I think is accepted. So the number of inpatients reduced, and so patient dining diminished. But the question of how we kept hard-pressed NHS staff, clinicians, kind of fed and watered, given Professor Wilson's comments about potential sources of infection, gathering areas. How did we deal with that? Because I'm going to add one more sort of supplementary point to that, which is that a lot of people had great intentions. I mean, organisations in lobbying endless amounts of free this and free that at hospitals. In many cases, I think you'd say it kind of got in the way of helping us to deliver services. I don't want you to be politically correct on this. You've got to call it as it is. But before you do that, just tell me about how some trusts moved to provide free food for their NHS staff on site, so they were able to not have to worry about how they got fed and watered. And maybe, Anna, how you helped Gareth to create environments that were free and safe of infection in order for people to gather, albeit socially distanced. Sorry, there's a lot of questions there. Hopefully you can remember them.
I guess if we tackle the free food question first, and free kind of supply, which is the right thing to do, by the way. I think the teams on the ground for that first 2 to 3 weeks, it was needed. I think in essence, the way that the food kind of flow was delivered didn't assist with what we were trying to achieve inside the actual facility. A lot in my case at my trust, the actual free food service was delivered through an education centre, where social distancing was sketchy at best, and I think the flow of that kind of clinical team didn't quite match up to what was expected inside the actual facility itself, which added extra complexity, and I think links to what Professor Wilson mentioned within UCLH as well, and around tea room activity and so on. I guess if we're looking at how we assisted the trust as a business in terms of creating safe eating environments and spaces for colleagues to go and relax and enjoy their food, I guess from a Compass Medirest perspective, we were quick to move to that plate, and I guess that comes from Anna's lead and the central team's lead in terms of giving us guidance in terms of how we can position our tables. We were quick to move all of our actual seating areas and so on out of all of our retail areas. I think we were one of the first kind of to do that within the organisations that I've spoken to along the way, but still moving away from delivering kind of a crockery and cutlery service to takeaway. We were constantly adapting through the process and allowing that social distance, allowing those contact and high touch points to be diminished. And I think if we could do this again, and we were looking to give a free service back to the NHS or the key worker colleagues, I think they should lean on us more, personally, be the thought leaders in that process, because I think we could have done better, and I think we could have given a better service overall. That's just my own personal opinion. And I think with our ability to lean on food buyer for support in terms of getting especially the essential items brought into our environments, especially within my trust, toilet paper, for instance, toilet paper gate, we were able to get that in quite quickly, and believe it or not, that was one of our top sellers for a little while. So I guess if looking at more of a positive side, and I guess if we could have spoken to Ian and his team more through that process, I think we could have actually been a much better partner through that process. But hindsight's a wonderful thing, and I think the trusts in general will be learning from their experience through that as well, because I think they will still be paying for some of that food post-COVID, if that makes sense.
It does, and don't apologise for hindsight. That's the whole purpose of this webinar, is that we need to benefit from it. Just jump across to Ian if I can. You know, we realised very early on that the prospect of hard-pressed nurses and doctors and other clinicians working flat out on a COVID shift and having to stop off on the way home to get essential supplies was going to be a challenge. Tell me how you help the businesses, particularly the healthcare business, to establish what were effectively mini marts. Just tell me a little bit about that if you can.
Yeah, sure. Yeah, I think I touched on it earlier. I think what was really evident was that the retail supply chains were really struggling. So people were panic buying, and going into supermarkets was like empty, barren shelves. And the problem for that was that the supermarkets profile of products they purchase are very much retail pack formats. So we knew that we were going to struggle to get retail pack formats, but actually what we had an abundance of in our network was catering pack formats. So we knew we had the same products, they just probably weren't in a consumer facing pack format that was suitable. So quite quickly and early on, what we defined is a process to be able to decant those larger pack formats from the catering environment and make them retail ready. So what that enabled us to do was to get those critical items like toilet roll, like pasta, like rice, that tin tomatoes that people were really struggling to get hold of. We could quite quickly get them out of our network into the places where they were needed with an appropriate process to repack them, and therefore could get them to the people that needed them. So I think so through that, I think we delighted people, because they didn't expect us to be able to do that in the manner and the speed that we did it, and with the pressures of the supermarkets, it was some nice light relief for them. And then I guess
these mini markets, were they located sort of co-located in the restaurants? Is that where?
Yeah. So we kind of set them up next to where we would have a convenience store or a Costa, you know. So we kind of, it was a bit of like, I guess you would call it a bit of a pop-up store. So these stores popped up overnight, had those essential items that people really needed. And then we work with Gareth and people similar to Gareth in those roles to kind of continue to evolve that range of products, because as we've just talked about with PPE and the evolution of what people wanted, it was the same with these products. So people got stocked up on pasta and tomatoes, and then it was different products that people wanted. So we continue to evolve and adapt. And then I guess another point that Gareth just raised on how we helped feed people, I guess that it has had a challenging situation in terms of packaging. So while our method of now being able to feed people safely in disposable packaging is a good thing, that has had a bit of a negative impact on all the great progress as a sector and as a business and as an industry we made on reducing single-use plastics and all those packaging items. So I guess in this phase it's the right thing to do, and I guess what we now need to work hard on with our supply partners is what are more environmentally friendly solutions for these type of packaging, if this packaging is to stay for the foreseeable future. And then also, how do we continue to improve consumer confidence in alternative methods? Because I think that was probably the thing through this pandemic we've gone backwards on, and I think that's something that we now need to look closely at and address with our partners like Catherine to make sure that we're, while we're buying things that 6 months ago we were really against buying, I think now we've got to make sure that if we do need to continue to purchase that we're buying them in the right way. Yeah,
I think it's kind of an any caught in a storm argument, isn't it? When your back's against the wall, some of the more lofty ambitions you have and aspire to, by mutual consent get parked. So Catherine, you must be quite confused by Compass, because we're pushing you hard to reduce plastics of all forms, and then suddenly we want 25 metric tons of plastic aprons and God knows what else. How might the industry continue to give clinicians and businesses the PPE they need, but in time actually start to move towards something more sustainable? Is probably the unanswerable question, but I've just asked it.
Okay, that's fine. No, it's a very good one, and it's still, like Food Buy and Compass, we are very keen, and it's top of our agenda in terms of sustainability. I mean, single-use plastic is not what we want to be doing. As we've talked about, I think before, is the business of, you've got the hurdle of, in terms of in some infectious, in healthcare, it is necessary with your chemical waste, that's going to be incinerated. So actually you're not going to start looking into those. But what we have done is things like, we brought out the first biodegradable aprons, those are now on the market. Things like tabards, drug-round tabards are biodegradable. There's still a huge way to go in terms of, we have compostable, biodegradable, huge debates about what is the most effective, and also how you dispose of it. And if it's not disposed of appropriately, again, you've still got the same issue. But for us, and again, cost, the price point for Anna's smiling because she knows, in the fact that we know that when we've talked to NHS buyers and said, this is what we can do, and we are getting a lot more questions, which is great, for people saying, actually, if I'm going to have patient carrier bags, I want them to be compostable, or I want, if we can do it at Morrison's or the Co-op, why can't we do it here? And the answer is absolutely right. And then, you look at the price, which is more expensive, and that tends to be, but it's getting there. The fact that we're talking about it is great. And in terms of, for us, R&D, we are really pushing forward on it, because, as you say, you're dead right. When your back's against the wall, you just think, we've just got to get this. And you need the aprons, you need the gowns, you need whatever it is. But actually, it's saying we need to really think about long term, because actually there's so much use of it.
Yeah.
You need to have alternative.
I think all those points resonate with me. Professor Wilson, where do you stand on this sort of equilibrium between effective PPE and something that is better for the environment, because there may be a cost impact? Are you and clinicians like you, are you influential in that process, or do the procurement guys reign supreme because it's all about the budget? Obviously, value for money and issues, similar issues, are very important to any organisation, public organisation purchasing. But I can understand Catherine's dilemma with this trying to meet a more aspirational sustainability agenda, as well as being effective PPE, as well as meeting some kind of budget. It's not an easy thing to circle to square, is it?
No, it's really difficult. I mean, I think most doctors would be very keen that this was sustainable and that we were not creating mountains of waste which are going to cause us even more problems in the future. But in the acute situation, I'm afraid that all just went out of the window, because people were desperately worried they were going to get the disease themselves, and indeed a lot of them did. There were quite a lot who had long-lasting health effects. And so people were really focused on having the PPE and not what sort of PPE it was. I mean, it is quite distressing that the government has bought in huge quantities of PPE, which it is now not able to use because they didn't fulfill the safety measures. And that money, I presume, is just completely wasted. Not to mention the amount of waste that's producing. So I think this is something where we can and should do a lot better in future, now that we've got that experience behind us, and we really shouldn't repeat what's been happening with the PPE.
Yeah. Thank you. I think that's wise words. Go ahead, Anna.
Could I mention that actually there is a piece of good news about sustainability around PPE. So the NHS have procured 3 million gowns, and they're reusable, launderable gowns that they've given to the laundry companies. So going forward, obviously there's been lots of disposable PPE in the past, but going forward there'll be these 3 million reusable gowns, which should make a big difference to sort of sustainability, and should really make a difference. They've been made in the UK, and I believe the fabric's also been made in the UK as well. So good story there.
Good, that's certainly progress, moving in the right direction. So if I can just turn now to something more general, particularly around people and motivation, and in particular employees on the front line delivering these key services. Now, I'm biased. I've always had a strong respect for cleaners and porters. I think in our own way, these individuals are as key as clinicians, because the hospital simply can't operate without them. And I always like to remind people that they are there to help make patients better, or in some cases save lives. So I do think, if I could be on my soapbox for a moment, that quite apart from the clap for carers and the Thursday clapping, etc., I think this kind of silent army of vital support services people, particularly cleaners, porters, food service assistants, have now kind of become more visible. They have a higher profile. And I'd like to think that an individual would never say ever again, I'm just a cleaner, because they're there on a mission, and that mission is to keep the hospital infection free. So Gareth, let me turn to you and say, I'm gonna, obviously the rock stars of the health service are always going to be the clinicians for sure, but I would say in the public's eye, I sense a distinct improvement in the perception of the value that our frontline staff bring, particularly delivering those services. Are you seeing that in a reflection of your teams and of the things we've done to support them?
Hi, Steve. Yeah, I guess if you're looking at the perception from the team, from the community and so on, they're definitely getting a lot more kudos than they would normally do. And I guess people are taking more notice of just a strange example. Our kind of cleaning office, on the door, we've had little pictures from children that have been stuck on the door with pins and stuff saying thank you to the cleaner and things like that. If I cast my mind, I've been in healthcare now 8 years, believe it or not. I've never seen that before, to that level of kind of gratitude coming through from the community. I guess from a people perspective, we're definitely seeing the confidence growing within the FM teams, and I think not just the Medirest teams as a whole, but I think all non-clinical support teams within the trust. I think the unsung heroes are now starting to realise that they do actually maybe wear capes, and they're trying to get out there and show everyone what they can do. The clapping for the NHS and for the key workers definitely brought out something special within the teams. It's nothing short than amazing, really. So I guess that motivation that was driven from that is something I wish I could have bottled it and kept for a later time when we needed it again, you know, because that level of kind of engagement, that level of kind of desire to do better was amazing. Again, I guess the people, we haven't really touched them, but our shielders and colleagues who have worked for the NHS for a hell of a long time, who have TP'd over to our services, we've missed them as well. And then just generally the feeling that they've got from our own teams, from the community within the trust, community in their own areas with the clapping and so on, has definitely motivated them as well, as we've touched in with them. As they've returned to the trust, I guess their confidence being locked in for this period of time has also been knocked to some level. Mm-hmm. And just them walking back into the site and getting that kind of pat on the back from their colleagues, the trust themselves, and just general patients and people who are within we've got some patients that are with us for a long time who miss these colleagues while they weren't there. So I guess all that type of stuff is definitely given them a different profile, given them a different exposure, and definitely motivated them at a different level. I guess it's our job now to figure out how we harness it and keep it going, really. And I think that's a bigger piece that we need to think about. But yeah, no, it's been amazing to actually see that unfold over the last 3 months. performance.
And were you able to do anything else on site in terms of bonuses or long-term pay reviews? I mean, obviously these are difficult things because cost is important, but you know, given that we're placing so much emphasis on these individuals for the health and safety of patients in hospitals, you know, we've got to recognise the key role that they play. So, what were you able to do?
I guess Compass as a whole and Medirest as a whole, we took quite an early adoption to how we can reward our teams quite swiftly, and we implemented a bonus scheme for these colleagues within the management teams and so on. We also looked at a pay review across all frontline staff to make sure that everybody was getting paid equally, and I think that went a long way to kind of making those colleagues all feel a part of one team, and kind of break down those barriers that potentially may have been in the past through kind of procurement practices and just the world that we live in. I guess Catherine mentioned around the price pressures the NHS face. I guess that has driven some of those outcomes out, but we've managed to literally flatten that out, which is fantastic. And I think that's definitely helped from a morale pay point of view. I guess just from a kind of more softer side, I mean, what Ian's team did in terms of the care packages and so on, delivering that to sites, was nothing short of amazing again. I didn't think that a box with a few key essential items would bring that much emotion and kind of touch my team in that way. I thought money was always the driver, clearly not. And it was really special to see them get their boxes. I was fortunate enough to have my client with me when we were dishing the boxes out to our teams, and even he was really surprised in terms of the emotion that was coming across from our colleagues. So that's something that really hit home for me. And I think we're always trying to fight the good fight to try and drive that hourly rate up, but it's sometimes the small things that are actually worth more than the final paycheck. I guess the other things that we did in terms of a team kind of motivation point of view is just trying to make things a little bit more fun around the sites. I think we get stuck in the drive of being, you know, full-time business, full-time looking at cost pressures, CRPs, you know, trying to become more productive and all the rest, and we lose sight about, you know, what are the colleagues actually there for every day, what makes them get up in the morning, and what makes them walk into a hospital full of COVID patients. And I think, you know, to make it a bit more fun and exciting, get the managers more on the floor, get them out of the offices, get the supervisors more engaged, and level up. So break down the barriers that were there before, potentially through hierarchy, and stand shoulder to shoulder with the team was definitely a plus.
Yeah, and I certainly have seen lots of evidence of that. Many of you may not know, but Compass has the Facebook equivalent for business. It's called Workplace, so it's exactly the same as Facebook, but it's Workplace, and it had become a shop window for best practice and lots of the sort of somewhat more light-hearted stuff. And what I noticed is that once there was a momentum from the 20 sites posting to Workplace, it created this amazing sense of esprit de corps, that they were in it together and they were sharing ideas. And you know, for me, it was the highlight of my day, just checking up to see what the latest kind of initiative was. And I'm so proud of what you guys have all done on that front. And so Workplace has been a definite tool of collaboration and connection, and thank you for Ian for, you know, helping to sort it out. But I'm going to jump across to Anna, if I may. Anna, there may be a Professor Wilson angle here, but just tell me about some of the interfaces. We have day-to-day interfaces at sites, and Gareth will be attending endless control of infection meetings, but at your level, in trying to either influence or shape those connections to trusts, can you think of any key meetings where you've helped to influence a decision, or you've been asked to change process as a result of a trust's particular need? How does that kind of strategic influence work for you in control of infection?
I think in the past, lots of hospitals have worked independently, and individual infection control teams have done things very individually. And I think this has brought together, I think, like Ian was saying earlier, a collaboration. Everybody's collaborated together. So we've worked with NHS estates and improvement and our FM colleagues to develop guidance that's used in all healthcare settings, not just the settings that we are involved in, so not just acute settings, but GP practices, ambulances, all arenas where healthcare is provided, to make sure that people have got guidance that works for them and SOPs that work for them. And the FM team have all come together to produce that guidance, and it's being used by everybody in the NHS. And if we could take one thing away, it would be that we should work more collaboratively in future on important things like guidance and making sure everybody is following best practice. So agreeing what best practice looks like, and working with clinical colleagues as well as specialists in FM to make sure that everybody is working to that best practice. And I think it's been a really good collaboration, and actually I think we'd like to continue that going forward, so that we make sure that things like the standards and policies are all working in the same way. And I think that's been appreciated by lots of people work across lots of different arenas, and I think it's been appreciated by NHS colleagues that they don't then have to develop their own guidance. It's been developed for them. So that for me has been a really good way of working.
Ian, you wanted to say something?
Yeah, I was just going to say, I think from a procurement perspective, and I think Catherine would agree from a supplier perspective, having people like Anna as our SME experts has definitely been a hugely valuable thing through this period of time, because my procurement team don't have the technical knowledge or understanding in the level of detail that Anna has, and as you said, also the work with NHI as well means that my team can come to Anna with different options and solutions, and we're getting expert advice on what the best solution is for our business. I think you did procurement a bit of a disservice before when you said it was all about price, because I think procurement organisations are definitely evolving. I think price was probably a legacy thing that procurement organisations were driven on, but I think especially in this COVID period, the alignment, the collaboration between the experts and our supply partners is about making sure it's the right solution from a cost perspective, but also from a quality and a service perspective. And I do think this period of time will mean that we make better decisions for our business going forward, because we consider all those factors, and we've got to make sure that great link that not only does Anna have with my team, but also now directly with our suppliers in a way that wasn't there before, continues into the future.
Yeah. I think one of the other really good things is that the NHS have set up a regular meeting, so that it's a dialogue between all the FM suppliers and NHS estates and information, so we can have a two-way conversation about issues that we might be having, or things that the NHS are doing that might impact on us, where we can sort of plan and prepare and work more closely together. And that's been really valuable, and hopefully that continues too. And like Ian said, actually, our suppliers have been amazing through this whole process. Cleaning has never had more importance, and and that's really good that people see how important cleaning and hand hygiene are. And as everybody said, the amount of products that are being used, and the agility that the teams have had to have in terms of making sure they deliver the products that we need at the front line, so people can wash their hands, can sanitize, can clean and disinfect, has been amazing, really. And everybody in our team and our suppliers team have all really come together. I mean, I know, for example, that we spoke to Catherine late one Friday evening when we couldn't get orange bags, and they mobilised their new line on getting them ready for us, so we had them on the Monday of the following week. Those sort of relationships are critical and really make a difference to us and to our frontline colleagues in having the products they need to do their jobs.
Yeah, and I'll come to Catherine just in a second, but I guess the general observation is that in hospitals we've had alcohol gel and hand sanitizer on stands for as long as I can remember, and it's interesting to walk into just general offices now, shops, and everyone is following suit. So that general awareness, that societal awareness of how infections can transmit, I think is probably going to be one of the lasting benefits. It's probably not massively fun to have to do, but I think that's an education for the public at large. Catherine, did you want to add something?
it was just purely actually following on from Ian and Anna, really. But I think what's quite key about healthcare, and Anna mentioned it earlier, is the fact that because all trusts work very differently, the fact that actually we have got Anna in place who is liaising with all of them, and what we've learned from this, and one of the things that we've learned in our business, is that communication is so vital and has improved through lockdown, and that I think, Anna, you're experiencing, we've experienced with the NHS as well, but actually their communication has had to get better. So you are actually having those conversations, which is fantastic. And as Anna says, I do hope that we take that forward, that actually you are starting to get the collaborations and they remain like that, because we've shown what we can do. And I think that's a valid lesson to learn, really. So, but no, they're doing a super job.
Indeed, there's definitely been progress made. I'm just going to check in with our timekeeper, Sarah, who's on the line but not participating. Sarah, is there anything you need to say? No? She's still on mute. Okay, well, in that case, we'll plough on. We still have time. I mean, whilst this isn't a clinical discussion, because that's really not what we're about, I do want to come back to Professor Wilson and say, look, there have been some good UK-based kind of step forwards in terms of standard treatments, therapeutics that have been adopted for COVID patients. We've heard about, the name escapes me for the time being, the sort of fairly generically available steroidal drug that would help certain patients. Obviously, there are some vaccine trials at Oxford and Imperial going on. I think there's the whole thing around remdesivir. Is it your view that if a similar kind of wave occurred again, a combination of those medical treatments and just better experience of treating the symptoms may impact on survivability, the number of people actually becoming critically ill and going onto ventilators, etc.? How do you feel clinically that we may benefit from that experience?
Well, I mean, dexamethasone is a very widely available steroid, and it obviously did improve mortality. And remdesivir will cut the symptoms by a few days, but I'm afraid they're just chipping away at the edges. They're not going to be game changers. And I mean, our ITU, we had just over 35% mortality, I think. And at the moment, it's going to be fairly similar if we get a second wave. The patients get the illness. It's in the second week of the illness that they become seriously ill, and a lot of that, I think, is their response to the illness rather than the virus itself. And then, of course, some of them are in ITU for months and have permanently damaged respiratory system, and so they behave like anybody with chronically damaged lungs. There's, you know, and you manage them in the same way with the same antibiotics when they get infections. So I don't think that's going to change. Our best bet is prevention. So if we can get people to socially distance, if we can get them to understand how the disease is transmitted and when they are at risk, and then, of course, if we can get the vaccine in as soon as possible. At the moment, probably that's not going to be much before the middle of next year, but we have got still quite an uphill task ahead of us. Yes,
ironically, on the vaccine front, I think it was tested on a cohort here that were not particularly affected or exposed to the disease as the population generally recovered. So I think they've now exported some trials to Brazil and South Africa, I understand, which may which may be more prevalent, so could give better results in terms of a statistical analysis. Anyway, I think probably on that note, it might be a good time to end this webinar. I mean, we could talk forever because it's a fascinating subject, but it just really remains to me to thank everyone on the call, Professor Wilson, Catherine, Ian, Gareth and Anna, and obviously for Sarah and Lauren for organising it. We will do more as subjects develop, but I hope everyone listening has found it useful. I certainly have, and learned a few new things today myself, but I'm very grateful for everyone's time, particularly in the middle of this pandemic. God willing, the second wave, which maybe being hinted at can be controlled by local lockdown measures. We all live in hope. But for the time being, I'd like to thank everyone on the call and everyone who participated today for your time, and we look forward to seeing you all and speaking with you again soon. Thank you.
Thank you.
Thanks.